to see today. Are we all seeing the same screen at this point? Alana?
Yes, we are.
Everything's working well? Okay, great. So yes, I'm in a group practice at New Beginnings Counseling Center in Camarillo. We work with all ages of children and adults and their families who are not only dealing with eating disorders, but anxiety, depression, many expressions of trauma. And I run an intern training program as well as lead an adolescent and adult process therapy groups. And I provide somatic experiencing work with clients at nearby treatment centers as well. So I really believe somatic experiencing to be useful in my work with eating disorders, addictions, and trauma. So let's get started. And if my technology will work, we'll move on to the next slide. And sometimes I have a hiccup. Well, so I'm having a little trouble here getting the slide to move ahead. Alana, can you offer me any assistance here?
Yeah. Are you
There
just
we go.
having
It was just stalling. I'm not sure. Here we go.
Okay.
So we know that relaxation training and mindfulness works for clients, but what about those clients who come into session with so much upset that they can't possibly go into a relaxation or mindfulness exercise with you? So my goals are to teach you today how to interweave some of the tenets of somatic experiencing and to help your clients rebalance their nervous system so that all of those wonderful CBT, DBT, and IPT tools that you have, that you can pace them at a way that your clients can make use of them, as well as helping your clients discover their own system's natural capacity for perceiving a sense of safety, which then can lead to feeling a sense of calmness and pleasure inside themselves. For many clients, they perhaps have no recollection of that or very little. And then ideally, to build their ability to manage these tools in session with you, hopefully feeling better by the end of session, and apply them to managing upset outside of session, which then would develop more resiliency and certainly less reliance on their eating disorder. So it's not that we're training people on how to relax per se, but rather helping them develop the capacity to bounce back from upset and to utilize all of their good recovery tools. So what do we mean by somatic awareness? This is actually a depiction of the guys from the Kathy cartoon anticipating Valentine's Day, but it may be what some of our clients experience when thinking about or presenting the idea of somatic awareness. You can really discern the intensity of the mind-body connection as these three guys display, as well as we'll speak to the sort of learned avoidance of any body awareness. Developed eating disorders are trying to manage upsetting stuff in their bodies, upsetting thoughts and feelings, and they've had to take very desperate measures to try to feel better. So it's not surprising that by the time they come in for help, that they've learned to either stay very busy in their head or in their day using distraction. They might seem a little manic, or shut down, dissociated, or some combination of both. So you have a client who might come into session and cascades from one upset to the next with either flat affect or lots of tears and rage, and then is less and less able to stay present with themselves or you as they end up getting deeper and deeper into their story and their re-experiencing of it. Or as Peter Levine might say, kind of going back into the trauma vortex. So we need to help them stay out of the story with better ways to help them connect to themselves, to you, to their world in ways that feel better. And I'm sure for years many of you have tried whatever you could to help your clients be present enough to take in the caring you have for them, the skills that you know would help them feel, feel better, do better in their world if only they could receive them. And with clients with less trauma, that's easier than with clients with more trauma. So what do I mean by trauma? I'm going to define it as really it's a natural and normal part of life, not a disease or an aberration. Everyone experiences some degree of it. And we know that from Peter Levine and Daniel Siegel's work that the body-mind is designed to heal rather than hold on to a fixed way of coping, such as the compulsions, avoidance, or addictions that many folks end up developing. If you see the videos of the animals in the wild, you know that recovering from a fight or flight, life-threatening experience, recovering from that can actually happen quite rapidly and without any symptoms of PTSD. Our limbic systems in our brain are quite similar, and yet why do so many people get stuck? So if we look at trauma as an injury to the nervous system, manifesting as distorted thinking, feelings of overwhelm, and physical distress, then we can decode where our clients are stuck in their process of trying to recover from that injury. That trauma is held in the body, not in the actual traumatic experience, and certainly not in the story of retelling the experience. But rather what happens is there tends to be this combination of negative or fearful thoughts as the client may retell or re-experience that frightens them. And so that continues to escalate the client's arousal, finally to the point where they need something really powerful, like their eating disorder behavior, in order to feel better, at least in the moment. So understanding these behaviors as an attempt to balance an upset nervous system can help us develop better ways for our clients to not only manage from the top down per se using insight, cognitive understanding, CBT tools, but also from the bottom up, developing awareness and tolerance for being inside their own skin, that they have a body container, experiencing their bodies as a safe container for their thoughts, their feelings, and their memories. I'm curious how many of you may have worked with clients who brace against any awareness of their bodies. Pretty common, especially in terms of working with clients with eating disorders. And I want to speak to that a little bit, that trauma is an interoceptive experience. It's an experience that's happening inside our bodies. It's not so much the external events that are traumatic, and therefore when we think about it like being stuck, as it is the body's inability to manage the flood of internal sensations and accompanying thoughts and feelings, that there's no way to release them. If someone gets threatened and they're able to run away successfully, they're not likely to experience any residual effects of that experience in terms of what we think of as trauma. But that's not what tends to happen. There's an overwhelm in the internal experience. So then when clients have another distressing internal experience and they don't know how to manage it, those sensations, and again they start to get scared, they often become fearful of that and develop ways to at least avoid the internal experience. They can't control external events or what we might call triggers, but they can avoid the internal experience. And so many clients have a phobic response to any sort of relaxation or mindfulness exercise. They may fear another flood of internal sensations and accompanying thoughts and feelings that they don't have a way to manage. So for them, we need to be able to offer ways to access their own relaxation response that feels safe to them. So for example, when approaching, we know that mindfulness and guided imagery is an important piece of training people into the relaxation response, and that people with more trauma really need more structure and containment in those types of exercises rather than the more self-directed sit and breathe unstructured meditation practices. As Anne Lamont has said, my mind is a neighborhood I try not to go into alone. And that's really very true. We really want to be present in accompanying clients as we start to help them move into their internal experience. So somatic techniques have been very powerful in terms of making positive changes with with resolving trauma. This work here by Bernard Benson and Isaac certainly has supported Peter Levine's somatic experiencing work and Pat Ogden's sensory motor psychotherapy work. Part of the notion of it is to separate out just the sensations that are happening and to be able to track that. If clients can do that, they will likely experience a change in the intensity. And they can improve their ability to manage upsetting events or PTSD or trauma triggers by helping them focus just on the sensations, rather than what often happens is the sensations tend to keep increasing due to, again, that negative thought cycle or the getting scared of what's happening inside and then having some negative thoughts or fear or judgments about that. The idea is we're trying to interrupt the snowball effect of something bad happened, I feel sick to my stomach, I think about how stupid I was, then I feel more nauseous, then I start to panic, and then I need to eat or restrict or purge. So redirecting to sensation can at least at first begin to provide an interrupt, and then we're going to attempt to move into helping clients notice what there is this natural pendulation of arousal and release. So this is the experiential exercise I tend to do with demonstrations I'm doing with people live. I want to just spend a couple minutes trying to offer you a little piece of it to hopefully help you experience what's happening inside of you. And again, it's not a relaxation that we're going for or guided imagery per se, but really wanting to help you anchor the observation of your own nervous system, of what's happening inside. So I'm going to invite you to just take a second to see if you can orient to your surroundings. Perhaps notice what around the space that you're in right now your eyes are attracted to. If there's any sounds besides the sound of my voice that might feel pleasant to you. Kind of noticing your surroundings and what begins to strike you as pleasant. And if you're able to do that, you might begin to then be able to tune in and notice what's happening inside. And there you might experience, at first, sometimes we tune in, at first we experience discomfort. And if so, can you tolerate just allowing that sensation to be there? Noticing perhaps what's happening in other areas of your body. And as you keep changing or shifting your focus, or if you can also just hang out with whatever the sensations are that are happening, you will tend to notice that they start to move or change. They may get more intense for a little while and then start to subside, again, especially if you're able to sort of focus in and tune into something that feels pleasant at the same time that you're also experiencing some tension or distress. You can also notice if the distress doesn't feel tolerable, that pull to move away from it. And again, just kind of noticing what happens next. With the sense of, I am a dynamic system and things are moving just like the tide moves in and out, that there is this natural arousal and then release of energy and arousal again and release. And by repeated accessing of that release or that sense of relaxation, we can reverse these arousal systems in the body and mend the wear and tear on ourselves brought by stress. So again, this is, of course, certainly taken from all of those good works of mindfulness and meditation. And how do we just begin to do it on a much more micro scale? So good for you if you were able to really kind of notice that oscillation from maybe tension and discomfort to relaxation or discharge. But I want to talk about what interrupts our client's ability to do that, this normal and natural movement from what I might call, or Peter's called, pendulation between arousal and rest. And so we're back to talking about trauma and actually how it manifests as a physiological response in the nervous system. This is not a psychological response. What our clients are doing and how they're exhibiting is all physiologically driven. So I want to take a moment and kind of look at the workings of the autonomic nervous system, since this is the part that's in charge of self-regulation, organ and metabolic function, and also plays an essential role in regulating our moods and our energy levels. And this system is also always looking for ways to save energy, kind of like going around and shutting off unused lights, attempting to return to an energy-efficient state that we might call homeostasis. And this balance is based on these two branches, sympathetic system and the parasympathetic. Some people call it the stress response and the relaxation response. I'm kind of a car person, so I like to call it the gas pedal and the braking system. So the sympathetic system, or the gas pedal, is, we know, in charge of pumping us up, energizing us, creates feelings of excitement as well as feelings of stress. And the parasympathetic system is the braking system. We know it operates to calm down the energy in the system. Again, might help us feel relaxed. It's also in charge of immune system support, cell repair, of course, all of those things that are kind of in for the marathon of living, helping us conserve energy and maintain our good health. And then I want to point out this one part of the parasympathetic system, which is the vagus nerve. It's, if you compare if you call the spinal column as one nerve, the vagus nerve is the second largest nerve in the body. And it begins in the brain, travels down alongside the esophagus to the stomach and the other gastrointestinal organs. And it's primarily responsible for autonomic regulation involved in the heart, the lung, and the gastrointestinal function. It controls much of the activity of the stomach, the intestine, and as well as playing an essential role in controlling the sensations of hunger, satisfaction, and fullness. And I belabor this part, particularly in my eating disorder talks, because I want you to see that how the vagus nerve acts has a significant impact on our gastrointestinal health and function. And what triggers how the vagus nerve is going to act is keenly intertwined with how we perceive threat or safety in our environment. So our gastrointestinal health and function inextricably dependent on our perceived sense of safety. I'm sure many of you are familiar with this slide of really kind of talking about what we know of how the brain works and how it's able to respond. You know, ideally we have this lovely neocortex, but then of course we know there's these trauma triggers that happen and we're operating kind of out of our limbic system. And then if we feel life-threatening or extreme danger, that we have left is we're operating out of a reptilian part of the brain. And this is our evolutionary heritage. We're hardwired in how our nervous system responds. And so I like this slide because I'm going to keep coming back to this green zone, yellow zone, and red zone as we continue to talk today. So thanks to Stephen Porges, we've got kind of a model here of how the nervous system interacts with the environment and how we're wired to respond to, again, perceived safety or perceived threat in our environment. So the most advanced and unique to mammals is what he's called the parasympathetic ventral, or the new vagal system. We also call it the social engagement system. If we feel safe, then we're in the green zone. And this, of course, is our optimal arousal zone. Or we might call it, Siegel's called it the window of tolerance, Levine's called it the range of resilience. This is where good therapy and learning happens here, where we're able to connect with each other using eye contact, vocalization, facial expressions. When we perceive threat to our sense of safety, we attempt to use this response first. We get elbowed in a basketball game. Where do I look? I actually don't look at the ball first. I look at the face of the person who's elbowed me for interpretation. If he's just looking for the ball, then there's really no threat. This was an inadvertent elbow. You know, we're playing a contact sport. This is the braking system that we try to use first. Our social engagement. Try to read faces. It helps keep the sympathetic mobilization, that branch quiet, conserving our energy. But if I perceive that there is a threat, then my nervous system is evolutionarily designed to move into the yellow zone next. So my next response that I attempt is a sympathetic response. Attempting to move into, my choices are now more limited. My choices are either to get out of there or find some way of fighting. And of course, this starts to create a state of hyperarousal. And if this is not effective or we're unable to, certainly I think an obvious example would be a child who's feeling threatened by a physically intimidating adult. They're not able to run away, and they're not able to certainly fight effectively. So what's left then is this experience of life threat. And what we have left to revert to is that reptilian part of our brain, or using what happens is the parasympathetic dorsal, or the old vagal system, is our most primitive responder. It creates a state of hypoarousal, immobilization. Our protective reflexes of fight or flight are then shut down. We see it in the wild as a predator is chasing his prey, and the prey is realizing that they're not going to be able to outrun. Prey might collapse. So both, one, perhaps giving an illusion of being dead already, and a predator's not going to want to go after dead meat, but also the parasympathetic goes into releasing endorphins to cause a more calm experience of death. So for us, it's not that when we get into this zone that we're feigning death per se, but we're in that state of immobilization. We can't connect to others. We can't move forward, whether it's temporary, and perhaps, unfortunately, if we get frightened while coming out of or going into this state, it prolongs that experience. It sort of reinforces the frozen state. So clients often come into therapy in the yellow zone or the red zone. We notice them either often in a state of hyperarousal or a state of hypoarousal. They're kind of relying on the survival system and not able to reconnect to this place of safety or neutrality in the green zone. And therapy or learning really can't be very effective until we assist them with experiencing a sense of perceived safety for themselves. Not telling them that they're in a safe place, but really rather coaching them on discerning what feels safe to them, or even what may start off with what feels threatening to them, and how do they know that. So again, kind of emphasizing this part that these responses are physiologically driven. And here's a great example of what you might, experience with your clients who tend to do this roller coaster of acting out behaviors and then some pretty severe kind of acting in or shut down behaviors. And what we see here is the interactive result of the sympathetic, I've kind of labeled up here, the yellow zone, and the dorsal vagal roller coaster response. And this is particularly common when there's attachment trauma, because that lack of mirroring from caregivers results in a lack of proper myelination or development of the ventral vagal system. So there isn't much ventral vagal or social engagement breaking going on to inhibit the sympathetic response, which then, of course, also, as we know from the previous slide, also inhibits the dorsal vagal response, the shutdown break. So when the ventral vagal braking system isn't there, this is what occurs instead. The nervous system is still striving for homeostasis, but we're not able to kind of tap on the brakes. Instead, there's like this gas pedal surge and then kind of a slamming on the brakes. This heightened hyperarousal, and again, the body's not designed for prolonged periods of being in a state of hyperarousal, so it takes us, slams on the brakes however it can. We end up in a state of hypoarousal. And this roller coaster ride, because of these energy systems, are pretty predictable in that as high as we go, the more intense someone's hyperaroused state is, the more intense the complementary parasympathetic response, that dorsal vagal response, which is really sort of all that the person tends to have when they don't have a great social engagement structure in place. And so this is, again, what we see is this really intense parasympathetic response. So this is what I might see coming into my office. I don't have any live demos of clients, but I brought in my friends the turtles, kind of demonstrating again what hyperarousal and hypoarousal might look like in couples counseling. Clearly, Mrs. Turtle in a state of hyperarousal, kind of in fight mode or in the yellow zone. And Mr. Turtle, not available, might consider him being in a state of hypoarousal or a free state in that red zone. So here, Mrs. Turtle, these are the symptoms of what hyperarousal looks like, kind of this stuck on or in fight mode or flight mode. And again, Mr. Turtle in that place of, at the moment, in the off position, these might be the symptoms that we'd see for that. And here in the middle, again, let's just kind of point out the jagged red line is really that biphasic roller coaster we saw on the previous slide of very little in this nice range of resilience. This is really what we're going for, that ability to experience a little bit of awareness of arousal and then have some discharge of that, and then again. And for clients, this window may be very narrow. We're really trying to help them access any types of sensations that they feel are tolerable, which then increases over time. Even if it's only 3 seconds of, oh, that feels okay, in between awareness of sensations that might feel worse or intolerable. I have another animal friend here, the fish. I know it's foolish. I mean, hey, I could end up gutted. But it's such a rush to go right up to the net and then snap the line. How many of your clients seem to ride those rails, so to speak, of thrill-seeking or dangerous behaviors and then crash and burn? And what I try to point out in this slide is anxiety or excitement. If we take a closer look at what our clients consider relaxation, sometimes we might discover that it's really more arousing experiences. And I'm certainly one that falls into that category. I'm an avid snowboarder, and I really do go for the thrill of that 3 seconds of flight in the air off a jump. And sometimes I do crash and burn. And so while I think of snowboarding as a relaxing part of my self-care, I really have to take a look at that I am stressing my nervous system. But it's a way in which I also feel alive. And so for some clients, we might have to start the conversation there of helping them to notice the thrill of arousal when they're engaging in something that does help them feel alive. It may have some disastrous cost to them. But then we have a chance to kind of uncouple the merger of the physical sensations from judgments or associations when we can start with talking about something that feels good to them. And I really find somatic experiencing to be useful in this area because we're helping clients to notice energy instead of the positive or negative balance of emotions or self-statements. So we're really building tolerance just for the energy that's going on inside of them without the judgments. So with a client, it might look like me saying, well, of course you have a judgment about feeling angry, if that's an unacceptable feeling in their mind. But then I'm going to gently prompt them back to, could we just come back for a moment to the sensation in your jaw and help them explore that. So this is kind of the nuts and bolts of what I call interpersonal somatic psychotherapy, really being mindful of how we structure the sessions, using your own body resonance, and so that ability to do something similar to the exercise that we walked you through earlier, being able to track your own rest and relaxation, using some sensory language, being able to pace that within your client's window of tolerance, noticing how your client shifts in and out of engagement with you, and of course, really always moving that interaction back to the window of tolerance. So if only our clients came in with clear signs like this one of where they were. But instead, we're really trying to track their level of arousal. You've got a client who comes into session. She may be upset about eating something she feels badly about, or having upsetting thoughts or memories that are coming up in treatment. She may be crying, perhaps pacing in your office. maybe unraveling the fringe on the blanket on your couch or pulling the legs off a squishy toy. How do you know what's a healthy release of pent-up emotion and what's actually reinforcing an emotional over-response to the situation? So I try to offer a willingness to assist clients with pacing our time together in a way that doesn't overwhelm them. And so right from the beginning, I'm inviting them to take a moment when clients first come into my office. It's just kind of standard routine for me to help them orient to the surroundings of my space. I have squishy toys, I have blankets, I have pillows of different textures, really inviting them to find out a place that's comfortable for where they sit. And again, notice how they know. That's this sense of helping them create their own sense of safety. And inviting them to check in and see if something might feel even better, putting another pillow behind them. Also noticing, if they're able to, where I'm sitting. For some clients, I can tell that perhaps they're really in a state of that red zone, and that's going to be more than they can tolerate. But if they can, I'm now introducing, again, some of this social engagement of you're there and I'm over here, and does that feel comfortable enough for you so far? Am I far enough away and or close enough away from you? And so these are kind of the 8 pieces of what I'm going to kind of walk through now a little more specifically, of using the principles of somatic experiencing, this idea of finding what we call resources, being able to track physical sensations and do that with your clients, focusing your attention and eventually their attention on that S-curve of arousal and release, and eventually being able to pace that in a way that supports coherence and more resiliency. So we're back to this working within the window of tolerance and starting off with you trying to assess your client's level of somatic arousal. Are they teetering, in the yellow zone? Are they definitely in the red zone? Are they able to do any of this naturally, while they're breathing? That's a good sign. They're sitting on the couch. They're making eye contact. Okay, wonderful. Can they tell me any aspects of that, of what they're noticing around? Can they tell me they like the trees outside my window? All of those things are really both engaging and orienting for clients. And then trying to redirect to prevent, whenever you can, hyperarousal or hypoarousal. The idea is less is more. If we can assist clients to leave the session with more integration and resiliency and a subjective experience of feeling better, our work is done. The more that we're able to slow this process down and really help clients notice bracing or tightening and being able to tolerate that, now they've got a sense of mastery of what's happening with them. So sometimes this is challenging because when clients start to feel good, and good, of course, may be on that track of arousal, they can tend to push themselves past their window of tolerance, since they're kind of not used to noticing the internal signals of distress. And then, of course, that results for the need for something powerful or some anesthesia again. Now, in terms of level of care or level of containment, this is where we have some advantages. Those of you who are working in all-day intensive treatments or residential treatment or inpatient, you've got a larger container around your clients. So you've got outside the session other places where they can find some ways of safety or expressiveness. So you may be able to do the pace and the depth of the work a little bit deeper because you've got more containment in your environment. So what I might say to clients, again, is once they're able to begin to notice some internal experience, or they may not yet, but I may start to give them some feedback if they're able to kind of engage with me. I may offer, gee, I noticed your shoulders seem to drop a little. Can you take a moment to notice what that's like? Or again, noticing tension is just as fine as well, being able to see the energy that may be in their fists, and what else are they noticing? So resources support resiliency, and really almost anything can be a resource. I affirm and validate to clients that their eating disorder is a resource. It's just that it's got some detrimental consequences. Clients' defense mechanisms, another resource, their beliefs. All of their behaviors are something that is attempting to support resiliency. And so I really underscore what the client is naturally using to be present with you and validate that. And of course, the tricky part is as we can see from the Dilbert cartoon, that any resource can also be a trigger for more upset. So a client may have a pet, and you know that that's a place where the client feels comfortable talking about their pet, thinking about their pet, and of course sometimes pets get sick. So being able to know that, of course, everything's in a dynamic environment, that there is no set resource. Even you, the therapist, who, typically you're a very powerful resource in this relationship. There are times when you miss your client's cues of what they need. There's times when you're sick, when you're unavailable. Of course, any of the parts of that relationship can, of course, become a trigger for additional upset. And it's the ability to begin to navigate that, make space for that, help the client. Again, we're sort of building distress tolerance for that. And so here's another example of what I might say, of really trying to engage the interpersonal communication about what I'm noticing that may be happening in me. Sometimes I start to brace inside, and I don't get a good read on what's happening with my client, but I might notice my own physical sensations, and I might share that. So, this might or might not be relevant, but, I can feel my shoulders tensing up as you're talking about this. I'm wondering what you're noticing. Or if I'm noticing about them, I may say, ask permission to comment on it and ask them to let me know if they can notice that bracing is happening. So in tracking that arousal and release, that gentle S-curve, we're noticing that certainly the more that a client can kind of notice, oh, I'm tightening, and then if they can hang in there for a moment, they might be releasing or expanding. If they find that they're having some trouble with that, I might offer to, again, notice what's going on at the same time as squeezing the squishy toy or noticing the breeze coming through the window, feeling their feet on the floor or the support of their chair. All of those things can be supportive and resources to help that release start to happen. The more that the client can allow that natural arousal and release to just naturally happen, again, we're widening their window of tolerance. And you may have to provide some assistance because they may get stuck. And then at times when clients their arousal feels sort of numb or flat, there's certainly things that I want to do to help them orient. We may be able to do some tapping exercises or squeezing. I may have them place, if they're able to tolerate this, place, kind of a motion of your arms crossed, but a bit sort of hugging your arms, maybe a way of creating some sensation of what's happening in my arms. I also will use other types of vibrations to help kind of assist in providing some the singing bell. This is a vibration I use. You can probably hear it in the background. I have a singing bowl in my office, and based upon the client, I'll either ring the singing bowl and have them just notice the vibration, or I'll have them hold the bowl and have them ring it. There's certainly a more powerful vibration that happens on the surface of your skin if you hold the bowl. Just being mindful of when there is kind of a shutdown or numb or flat, that person's in the red zone, and as we gently try to connect with them and help them out of that, there's going to be a lot of energy that's been compressed. So I want to be sensitive to that and really move from that place of them being tuned out in a very gentle manner, because they're going to be moving back into the yellow zone on their way out of the red zone. So I want to be ready for some intense energy that might get expressed when they kind of start to come out of the frozen state. So we're working to interweave and balance what's happening in the room, so again, that the good CBT and DBT work can be approached. So, for example, I might start the session with helping a client to attune to what's orienting or what's resourcing for them, and then I move into asking about their eating disorder symptoms, which of course is going to be arousing, right? Then we're going to resource again, kind of bringing them back to something that feels more pleasant or helping them take a moment if they can breathe. And over time, we start to get this pattern in place of this is the ritual that we do. So another tip on sort of how do you notice if a client is just having that natural, healthy discharge of energy versus moving into that more heightened state of hyperarousal. If a client's presentation is escalating quickly, that's more of a signal of hyperarousal. Here's some of the indicators that would show that. Healthy discharge, on the other hand, is released more gradually. The client is crying, they're still able to, if you say their name, perhaps look up and make eye contact. And really wanting to kind of hold that difference between healthy discharge and cathartic discharge, which to me tends to build and build and then break, which feels similar to me to that roller coaster ride. So I try to use analogies of, again, of like the gas pedal and the brake pedal, or kind of thinking about catharsis as that going over the waterfall, and how do we help clients kind of notice that I can paddle away. I don't have to, if I'm going to start to feel some things, I don't have to kind of go into the full experience of it. I can just tap into it a little bit. It's what Peter Levine calls titration. We want to connect with just the smallest amount of arousal that's manageable, and then be able to come out of it. And so ideally, then when my nervous system is balanced and my arousal is low, this is what I'm experiencing. And so that's why I always phrase my invitations as experiments. I ask someone if they're curious, if they're interested, and if I get a response, then I have a better sense that, oh yeah, they're more in the green zone. They're going to be able to participate in this experience. And if they're not showing these kinds of signs, then my work is to really go back and use all of those tools and resources that we talked about earlier to help them either move out of hyperarousal back into a more relaxed state, or start to kind of bring things to life. And so again, these pieces of tracking sensation, pendulating between arousal and release, doing it at a very titrated approach, less is more, pacing, we're helping clients move into a greater state of coherence from kind of being fixed in one state of being to being able to notice that their bodies have a regular flow. And so the benefits of integrating somatic psychotherapy is, of course, to deepen the client's ability to manage their feelings, wanting to be able to help them more quickly and successfully use mindfulness and grounding skills in a way that feels, again, safe to them. This then helps increase awareness and tolerance of hunger and fullness signals. If we go back to the polyvagal system and we know that the vagus nerve is giving us information about hunger and fullness, so the more that the client is in that green zone, they're going to be getting more of those signals about hunger and fullness. And then how do you help them, of course, manage that in ED treatment? This then starts to provide clients with additional resources on how to address upsetting events and triggers, which then, as we said before, reduces their reliance on their eating disorder. This idea of helping clients notice that they've got mastery over what's going on inside of them that they didn't have before. If we go back to this trauma as an internal experience, and there's places inside of me that I've gotten too afraid of to experience, when they're able to start going inside again in very small ways at the beginning, and being able to associate that with, again, their perceived sense of safety, then they get to reclaim that internal experience. Then the arousal or the nausea or whatever was uncomfortable, now paired with this experience of a sense of safety, dissolves. And so, oh, I can now manage what's happening inside of me in a way that I couldn't before. I can tolerate it. I can have that experience. I don't have to avoid it anymore. I don't have to run away from it, either literally or figuratively. So here's some resources of some of the work that I've used, as well as our website and the Somatic Experiencing website. I'm happy to provide this at a later time if you obviously can't write everything down here now. And so here's how you can contact me, either through our website or through my email. And thank you so much. I'm really delighted to be able to share this work with you. Looks like we've got some time for questions, and I know Alana's got just some announcements to make as well. So I'm going to turn it over to Alana.
Thank you, Susan. And Susan, if you can just go, I want them to actually take time to actually write your information down before we go to the next screen.
Oh, so.
Yeah, just for maybe just a few more seconds, just in case you want to.
Sure.
Your website and your email.
I can take questions as you have them.
Okay, great. If you can go to the next screen, I just wanted to share, before we answer questions, how to participate for the CEU. So participants go to the following website, create an account, and then go to Susan Baker's presentation. If there are any questions after this webinar that you'd like to ask, you can go ahead and email Ravi, and I think that's in the next screen. Yeah, so perfect. So email your questions to Ravi, and his email address is right there. He will also, because we know all your information, email information, he will be, the webinar, including audio and visual, will be up tomorrow. So in case some of you had come in late, it will be available for you to view tomorrow as well. All right, so we will be asking some questions now for Susan. So Susan, what's the difference in this theory with, I think, with mindfulness, or what's the difference in this theory and mindfulness?
In some ways, some of the basic tenets, yes, are the same. I think of mindfulness as having two advantages or two purposes to it. One is helping someone engage in the relaxation response, experience the relaxation response in their body. It's wonderful. Again, that really helps reduce the wear and tear. We tend to press our gas pedal more than we press our brakes. And the other great part of mindfulness, our meditation practice, is that, of course, my mind is going to drift or wander, and that retraining it to come back to the present moment or come back to the breath is a really good tool. You know, that neuroplasticity of, it's not that I'm trying to keep myself in balance all the time, but when I get out of balance, I notice myself out of balance, and I know what I can do to bring myself back. Yes. And what I'm trying to speak to today is that for particularly my experience of clients with eating disorders and clients with complex trauma, that being able to do that right off the get-go is too intolerable for them to experience, that they've developed a disconnect, a phobic response to going inside. So absolutely, if you've got clients that can tolerate mindfulness, wonderful. And there's always ways of checking. You know, if you do an experience with clients, I always suggest to start in the room with them in a very short period of time, and then find out, how did the rest of their day go? You know, I work in a practice setting where in California, In-N-Out Burger, you know, our wonderful fast food restaurant, is on one side as you leave my office, and the outlet malls are on the other side. So if my client comes back the next week and reports, you know, they had a shopping binge or, you know, had a swing by In-N-Out, tells me that that was too much. We did too much in that session. Mm-hmm. So what I'm trying to present today is, how do we go in a smaller dose? How do we just help clients touch in, or even just touch around, to notice that things in my environment may feel pleasant, and that starts to begin the open door for eventually, sure, love to get them into being able to do mindfulness.
Thank you, Susan. And we have another question here for you. What's your suggestion for a patient who is extremely resistant with this theory?
I really reinforce that. That goes back to the conversation about resources and their defenses. I'm really wanting to support them noticing the bracing. If they can tolerate that, you know, gosh, I really see your jaw tightening as I ask about this. Or sometimes I have a client who will say, you know, stop interrupting me. I just want to tell you my story. I just want you to listen. And I really, of course, I'm going to be respectful to that, but I'm going to say, you know, I really want to hear what you have to tell me. I think that your sharing of your experience is really important to me, and I want to receive that. And I want to have for you and I to be able to do that in a way that your system can manage. So I feel like my job is to try to provide some assistance when I might notice that I'm either feeling kind of too uncomfortable with this much distress, or when I might notice that it seems like you might be feeling more distress than is able to manage. So that tends to help, but of course, always starting off with validating, affirming, having empathy for exactly what the client's doing, because I really trust that we are creatures that are always attempting self-regulation, just with whatever tools we've got on board. And to support that notion then starts to make space for, oh, might there be some additional ways that I can self-regulate that might feel a little bit better. You there, Alana?
Hi, Susan. Can you hear me?
Yes.
Hello. Okay. Thank you so much, Susan. That's all for questions right now. Again, don't worry if you have additional questions. You could always email the questions to Ravi, and that email is on your screen right now. I wanted to thank everyone again for participating in our first webinar series. I found this webinar extremely informative and useful, especially for myself as a clinician. So thank you again, Susan. That was wonderful. And again, like I mentioned, it will be you will have access to this webinar, both audio and visual. And again, please email your questions to Ravi if needed. So I'd like to conclude with, again, just thanking everyone, and please be, we will be having a monthly webinar series, so please be on the lookout for our next webinar coming next month and the following months. Thank you so much. Have a wonderful day.